We're going to start with week 3 for Masters in Healthcare Administration 575, so healthcare quality, and looking at some information that I think will benefit you. First off, just checklists and reminders. In healthcare, the checklist, it's a tool for patient safety. It's a good reminder. It helps keeps us on task. The purpose is to ensure all steps are taken for patient safety and to prevent an error or an omission. So again, just making sure that we stay on the straight and narrow. A few areas where checklists are common includes in surgery, especially pre-surgery, making sure we have everything in place. Also with childbirth, trauma, and the pandemic H1N1. The other thing with surgery is inside the actual surgery suite, there's additional World Health Organization checklists that are of benefit. I know this is a little bit blurry, but if you go to the World Health Organization website, you can pull this up. You can even download the information to get a little bit better idea. But this is an example from the World Health Organization, and again, it's geared towards patient safety. It's talking about all the items that they need to do before anesthesia, what they need to do before the skin incision, and then actually before the patient leaves the emergency room. So it's very scriptive and it keeps you on track, focused, and everyone's involved to help make sure that the right thing is being done for the patient. Safe childbirth checklist. This is another one. Again, I know this is a little bit blurry, but just to kind of give you an idea, in this specialty area, again, the World Health Organization has tools and resources. Another very good resource, the Joint Commission website, is also the Agency for Healthcare Research and Quality, also known as AHRQ. It has some very good tools that you can reference. Trauma care. Trauma is just a beast. There are so many items you have to be taking into consideration. I know that our facility where I'm working, we're working on a Trauma 2 designation. A lot of work goes into it. So I thought this was interesting when I saw that the World Health Organization, they actually are working with a group of consultants to come up with more checklists. And it looks like it's more of an international component to get everyone on the same page so they can do some initial resuscitation, evaluation of these patients. Again, working towards decreasing morbidity for these patients and mortality. It's a high need, high risk with these patients. So again, they want to make sure everyone's on the same page. So it looks like they are further developing protocols, developing tools, and so this just keeps evolving. It looks like it's a little bit older slide because they were going to be releasing some more information in early of 2010. So this is just continuing to evolve. But I just thought this was kind of interesting to look at the diversity with the checklists that they have available. The pandemic H1N1. This was more for the clinic area, and this is just a section from it. This has multiple sections on this huge checklist, so it just kind of tells you descriptively exactly which step you need to do, what comes next, and it's a good reminder, especially when you have a high-risk population. You don't want to expose your staff to injury. You obviously want to protect the patient, protect visitors, family. So this goes through every single item. The other thing we utilize at our facility is we have isolation charts, and it's a flip chart. We keep it outside of each patient room so that if they have a special precaution that people need to take, maybe droplet, for example, respiratory, whatever the case may be, it helps staff and visitors alike to know what precautions need to be taken so that everyone is safe. Reminders. This gets to be a little bit more challenging. It used to be easy when we had our paper charts or hard copies of the chart. You could put flyers and stickers on the front of the chart. Now that we're getting more electronic, it's a little bit more challenging at times. But you can put some stickers if you have a paper chart, depending again on what arena that you work. There are flags that can be done electronically. It just kind of depends on your software and how much you can manipulate to make that happen. There's also some internal flags that are built in so that if you try to enter a certain medication, for example, it will request that you have a lab value. A classic for that one is if they're getting an anticoagulant like Coumadin or warfarin. They want to know if you've done a value to see what their bleed time is. So they call that an INR, just to see, are they at a level where that's safe for them to get that medication, and then also to see what their response is to the Coumadin. Also, there's alerts in software that we see all the time. Just when we go to close out of something, do we want to save it? Do we not want to save it? So these are all reminders also in healthcare and in software that just helps to keep us on track. Double checks, hard stops. We in the hospital setting, we're always looking if we're administering insulin, we're doing a double check on that. Chemotherapy is very, very high risk. So again, a lot of checks and balances. Same with also just the preparation of the chemo. It has to be done in a very unique environment. There has to be the negative airflow. A lot of garb needs to be worn to protect the person preparing the chemotherapy. It has to be a very clean environment. So again, lots and lots of checks and balances. Any kind of narcotic administration, especially when you're going to waste anything having to do with a narcotic, you want to make sure that if there is waste, that it's wasted appropriately and documented as such. Unfortunately, there are situations where you have people that are taking medications maybe for their own use or to sell. So again, there's a lot more checks and balances and hard stops built into this, I think, than what we even used to see many years back. Look-alike, sound-alike medications. We have lists that we keep near our Pyxis machines and in our medication administration areas. So again, we keep a track of that. We also have to have documentation from the Joint Commission requires, and I think CMS and state does as well. When we have medications like for pain, but maybe it's like a Tylenol, so you could give it for pain or you could give it for maybe a temperature, we need to have it spelled out specifically in that order why they're giving that medication. We can't just assume that they're getting it for pain. The physician has to really spell it out why they want that given. So we actually have some approved protocols of why those medications would be administered, and those two are listed or posted nearby the medication administration area. Best practices, and you may also hear it just called evidence-based practice. These are well known. The definition here is that by David Sackett and his colleagues, evidence-based medicine is the integration of best research evidence with clinical expertise and patient values. We see a lot of this with our core measures. So CMS and Joint Commission, they're working collaboratively to come up with best practices that we should follow for our patients. So examples of that. They started back in 1999, and the Joint Commission, they started working with various stakeholders, just trying to find out, what do we need to focus on, what can we do to help the patients have better outcomes. So they came up with the initial 4 core measures. I remember this very well. They started working with AMI, heart failure, pneumonia, and then some surgery core measures were the initial. So then they also got in the bandwagon with CMS, and so between Joint Commission and CMS, they started working on those heart failure, or the AMI, which is acute myocardial infarction or heart attack, heart failure order sets, and they wanted them to match. So they wanted to roll this information out to the public. And you'll see the 7th scope of work. That's what they call the scopes of work coming out from CMS. And so it was then in 2002 they really started collecting this measure, and staff started abstracting, and then we were comparing this information nationally to see how are we all doing. And with those specifications being used, we were all held to the same standard. So it was it was black and white, it was apples to apples when we were comparing what we had at our facility compared to other facilities, and it's still like that today. In November, they again continued to collaborate, created manuals, and these manuals, these dictionaries, these algorithms, they all do get updated pretty often. Anytime there's any kind of evidence that comes into play that has any kind of impact on any of these measures, then those are updated in these specification manuals. And you can go to QualityNet, which is the CMS website, to actually see the inpatient and the outpatient core measure specification manuals. Presently, in the acute care setting, these are the core measures that we are actively working on. Some of these are chart abstracted, some of them are just electronically abstracted, so certain cells within the software system extracts that data automatically. Some of the measures, as we have our processes down pat, they retire the measures. So again, it's always a dynamic evolution of all these measures. The one thing I want to point out is with the cancer, that's Commission on Cancer. They have what we call core measures as well, and that keeps growing. So again, it's not just the medical profession, it's also with the cancer, and they've rolled it out to the radiation therapy area. So it just keeps growing. And you also see rehab, they have core measures as well. So disclosure. I just think that again we need to really be aware that we need to have internal reporting systems. You might call them occurrence reports, event report, but staff need to be encouraged that they are there. We do need to know about them. We need to know if we have an actual event. We need to know if we have a near miss or a good catch. We've talked about that before. And then we also, if it is a medical error, then we need to make sure that there's notification to the patient and the family. Normally that's you'll have a policy for within your facility of how that's to be conducted. I know what I'm used to seeing, it's usually a member of administration and the physician involved or medical staff that do that actual notification with the patient and family. Depending on your state, you need to know what you have to report. I know Indiana has like 28 reportable events that we have to report to them should they occur. For us, we work with a corporation, so we're also reporting at a division level and at a corporate level. The Joint Commission is our accrediting body, so we're going to report to Joint Commission. Other facilities may have a different accreditation body, so they would have to escalate that information up to their accrediting body. And then also, I think this is good to know that if you have any staff member, any medical staff, and they have a concern, and it can be about safety or it can be about quality of care, they too can report it to the Joint Commission, to the state, and this is without retaliation from the hospital. So again, we want to make sure that all this information is available for them to share should they feel like that they're not getting a positive response within the organization. I think for the most part, most organizations are very open now with these event reporting and with following up and doing review of the cases and drilling down, doing a series of event analysis, a root cause analysis to get to the bottom of what's going on. But if indeed there is someone who feels like they're not getting a good response or any action from a concern they have, they can escalate it on up.